Welcome, everyone, to Here and Now, the Oncology podcast where we explore cutting-edge cancer care. My name is Biagio Ricciuti. I'm one of the thoracic medical oncologists at Dana-Farber Cancer Institute in Boston, Massachusetts, and host for today's podcast. And today we're diving into how to manage EGFR mutant non-small cell lung cancer. That's a space that's rapidly evolving. And joining me today, there is Dr. Corassa, a leading expert in thoracic oncology. Marcelo, welcome.
Hi, Biagio. Thanks for having me. Thank you, Oncology, for this opportunity. I'm a thoracic medical oncologist here in Brazil, in São Paulo, at PP, Beneficência Portuguesa de São Paulo. And most important, I'm a very good friends with Biagio, and it's a pleasure to be here.
Thank you, Marcelo. So for EGFR mutant lung cancer, we now have multiple first-line options we can offer to our patients. So can you walk us through these choices and the main trials that are supporting them?
So that's a very good question, and it would be very easy to answer if we were like 2-3 years ago. Yeah, the answer would be osimertinib for everyone, because we had a FLAURA trial, very direct trial, osi versus gefitinib or erlotinib, the investigator could choose. And we got improvements in PFS and OS, and it was a major improvement because we kept using gefitinib and erlotinib for a very long time. And that was for everyone. But I always say to my patients that the honeymoon tends to end. It's that 19-month median PFS that is over, and after that you get chemotherapy plus something. And that's the main problem. I always say that targeted therapy works this way. It's going to work and it's going to fail, and we need something else. And we got two sets of data. One that maybe it's easier is something that we did in clinical practice, which is the FLAURA2 trial that compared osimertinib monotherapy versus osi plus chemotherapy, also leading to improvement in PFS overall without an improvement in overall survival yet. We got some data in interim analysis number 2 that's showing a trend towards overall survival, but improved PFS, improved response rates, very good responses in brain. And we got the MARIPOSA trial, which was recently updated on ELCC. That it's a completely different approach. The control arm is the same, osimertinib for everyone, but we got this intervention arm with amivantamab plus lazertinib. Just for everyone to remember, lazertinib is also a third-generation TKI for EGFR. A little bit more toxic when we cross-compared data, and amivantamab, a bispecific antibody targeting both EGFR and MET, which works actually more in the immune response per se, than just blocking EGFR. And this got an improvement in PFS, and we got a benefit in overall survival in this update in ELCC, especially in those patients that we consider to have high-risk features. So we got the 3 options, and I was, just before we started recording here, I was having a discussion with the patient, and I just gave him osimertinib monotherapy. Exon 19 deletion, very small burden of disease, no brain mets. So, okay, so the 3 options are there, and they are okay, and it's our tough choice right now to choose between them.
Thank you very much for reviewing these 3 trials, so including the FLAURA, the FLAURA2, and the MARIPOSA. Today, these are our 3 choices. And we have these 3 major trials. All of them are phase 3 studies, but they're different strategies. So we have targeted monotherapy with osimertinib, combination with chemotherapy per FLAURA2, for example, and we have the combination of lazertinib plus amivantamab. So what would you say is your biggest takeaway in how we can tailor treatment based on patient risk profile or comorbidities? For example, do factors such as TP53 commutation, ctDNA, or brain metastases play a role into your decision-making today?
No, that's the million, maybe the billion, trillion-dollar question. I always say that we have to consider 3 things once we look into the patient. First of all, the patient. If you have an 85-year-old patient who is very frail, you don't have to think about TP53, you don't have to think about RB1, you don't have to think about uncommon EGFR mutations. You're going to give osimertinib to this patient because he cannot tolerate chemotherapy plus osi, and osi works. It's a very good drug. So it's hard for us to take patients from osimertinib and to convince them to have something else. So you have to look at your patient. If your patient is not suitable for receiving anything other than osimertinib, your choice is made. The second thing, you have to look into the scans, and symptom burden, of course. You have a patient with brain mets. I do think that intensification plays a major role in brain mets. We got data, very interesting data, both from the MARIPOSA and the FLAURA2 trials. If you have a patient with a very high burden of disease, this normally goes along with the molecular profile that shows that those features of worse prognosis. So if you have a patient who is very symptomatic, brain mets, lung mets, bone mets, liver mets, I think you should consider intensification. And since you are the person who I know who knows more about TP53, RB1, and all those features of worse prognosis, I think those patients, it's not written on stone. If you have a patient with a very low burden of disease, EGFR, exon 19 deletion plus TP53, is it really necessary to intensify therapy if you could give a better quality of life to these patients? Okay. And lastly, ctDNA. This is tough because you are there, your background says Dana-Farber Cancer Institute, and you can do ctDNA for like everyone. You guys who is listening to us here, my idea is that in the US, it's just like an espresso machine. You just put the blood in something, you put in a machine and say it's ctDNA positive. Here in Brazil is not how it works. Having ctDNA here, it's quite tough. And I do believe that the EGFR shatters, everyone should look into this trial. It's called EGFR shatters. It's a trial that was initiated in Dana-Farber that basically selects patients who have intensification or not based on positivity for ctDNA after 3 weeks of osimertinib. This is the future. I do think so. It's cost effective, probably yes, but it's tough for me because it costs a lot of money, and not only for me, but maybe if you were in Italy, you would have the same difficulty. So I think to summarize, if you have a patient and you see that patient, this is a high-risk patient, the patient's not doing good, this is the patient that you need to intensify.
Thank you very much for your thoughtful answer, because sometimes we tend to forget that we do have access to some resources that are not necessarily available everywhere across the globe. And so this is a major challenge when we do need this information to choose our first-line therapy. So that's a very thoughtful consideration, something we need to focus moving forward. But now that we have the MARIPOSA trial that has been reported in terms of platelet survival, this is the only study to date that has shown an overall survival benefit with a new therapy compared to standard of care EGFR third-generation kinase inhibitors, osimertinib. So the survival benefit we have seen was pretty impressive, I think, and clinically meaningful. So many of us are thinking or asking themselves the question, is this practice changing? Should this be our new standard of care first-line therapy? And is the added toxicity from this combination worth the gaining survival? I think there are different perspectives here. And so I think it's important for us to understand, what's your take on this?
Okay, so this is a tough question. First question is it practice changing? Yes and no. Because like you said, it's a new standard of care. You should just close your eyes and give ME plus lazertinib to everyone. No, of course not. Like you said, it's the first trial that we have with a meaningful gain in overall survival, and it's actually impressive. We were discussing this, I think 2 weeks ago at your place when I was there in Boston, that the curves were flat. They're flattening. We're having this plateau that we say in immune therapy, maybe because AMI works kind of in a immunologic way, but the toxicity is crazy. I've been an investigator for MARIPOSA, and it's tough. Sometimes because I didn't have all the experience we have in managing toxicities today, I was hoping for patients to fall into the control arm because it was too tough to understand. We didn't know anything about deep vein thrombosis. We didn't know anything about infusion reactions, and people were getting a lot of toxicity. So that's why I think this is not practice changing, but it has to be considered. It's overall survival data. And I do think that the FLAURA2 trial is going the signal is pointing towards overall survival. So I think it's going to be positive as well. We're going to have the plateau. I don't know, maybe, probably not. The plateau is going to be capped in MARIPOSA. I don't know, probably yes, who knows? But it's kind of deciding which patient should be receiving which therapy. And yes, the US benefit, it's meaningful. I understand it, but it's more expensive. It's toxic. You get infusion reactions, which for me is the thing that it matters the least, because after day one, day two, they're over, and after we give patients the proper pre-medications, it's also something that is very okay. But the rash, the paronychia, if you talk to a patient and they say, oh, what do you do for work? I work as a secretary and I type all the time. Maybe it's going to be very tough for this patient to keep working because of paronychia. So you have to share this decision with the patient, your patient. And lastly, we got data from MARIPOSA and Lazar. We go all in first line. If you give chemo plus osimertinib first line, you can have chemo plus amivantamab, because sometimes we drop chemo. The median time for chemotherapy in the FLAURA2 trial is 8 months, actually, 12 cycles, 13 cycles of pemetrexed. So we can challenge patients again with chemo plus amivantamab second line, and we got some patients with very good benefit, with a lot of benefit, very meaningful benefit as well. So I do think we don't know. Like I said, it was easy. We could be recording this 3 years ago, and it would be over 20 minutes ago, because it would be osimertinib for everyone.
Thank you, Marcelo. I think you touched on a very important point, which is the toxicity. And this is, I think, one of the last topics we would like to discuss today, because toxicity can be very difficult for patients, and we should keep in mind that we would like our patients to live longer, experience improvements in their survival, but we also want them to keep their quality of life, which is very, very important. So I was wondering if you could talk to us a little bit about how, do we manage the side effects from this combination, the amivantamab lazertinib combination in practice? You touched about infusion reaction, but skin rash, paronychia, those are big toxicities. And as you mentioned, the adoption of this therapy is challenging because of these side effects. But there are also trials that have been trying to look at pre-medication, preventive measure for this toxicity, as well as the subcutaneous administration of the amivantamab, which could reduce the infusion reaction. We have data from Cocoon and Skipper trials. So it would be great if you could summarize for us a little, how do we approach this toxicity as we now have to make this choice? And some of our patients will receive this combination therapy.
Yeah. Yeah, well, if we were discussing this recently, if you have a patient with an amplification in EGFR, maybe this patient is ideal for amivantamab, and you have to challenge this patient first line. And this very famous phrase, with great power it comes great responsibility. This is not Uncle Ben's from Spider-Man phrase. This is Voltaire, actually. And the drug works. It's a good drug. Gets response. So we have to manage everything. Infusion reactions are tough because they're scary. And you are not there in the infusion clinic when people are getting reactions. Sometimes it's people who just graduated from oncology fellowship. So you have to do everything to make these reactions easier. And I think the main thing that the Skipper trial, the Skipper evaluation wanted to address is dexamethasone. If you give 5 doses of 8 milligrams total, 5 doses pre-medication, you reduce by half the infusion reactions. Not only the incidence, but also the grade. You get more grade 1, grade 2. You don't get grade 3. And there is some stuff that I like to do. It's not on the trial per se. The trial had some ideas about giving methotrexate to patients, which I kind of don't agree, because maybe it's too toxic. But montelukast, leukotriene inhibitors work like a charm. If I don't remember my last amivantamab reaction, actually, because I'm giving montelukast for everyone. Histamine inhibitors like H2 inhibitors like famotidine, ranitidine, something like this. So, but the dexamethasone is the cornerstone of this of the therapy. Rash for me, rash and paronychia, they're the worst, because there's kind of a point of no return. If you just leave your patient getting ME, and this patient gets a lot of rash, like scalp ulcers, genital ulcers, the paronychia that prevents the patient from opening a bottle, bringing this patient back to reality, it's tough. So you need early intervention. I don't know how to do it. Ask a dermatologist to work alongside. Ask a good dermatologist. But if not, you just have to read and do what Cocoon, this trial says. And it's funny, I had a chance to open in Cocoon here in my center. I didn't want to open because I just said, I do intensive dermatologic care for all my patients right now, which is hydration. And it's important to say it's not any moisturizer. You need something that is hypoallergenic. If you give like Victoria's Secret Love Spell with a lot of color and a lot of smell, you're going to have a lot of maybe allergy. You need some specific cleaning of the nails with chlorhexidine. This is not on the trial, but I always advise my patients to use, it's not cream moisturizer, it's like a pomade. It's just something very, very, very thick in the nails. And you can have like petrolatum, you can have Vaseline, it's anything that works. And you should start doxycycline or minocycline if you don't have doxycycline in your country for at least 90 days, at least 30 days, I would say, for D1, C1. So these things, they reduce a lot of the toxicity. The rest, diarrhea, it's common, but you can manage with loperamide. Stomatitis, it's tough, and sometimes you need a good dentist to use laser therapy, but dexamethasone mouthwash works like a charm as well. So there are a lot of stuff. You have to remember that DVT is very common for these patients, and you should give your patients prophylactic anticoagulation and monitor your patient. Don't do like day one, C1, and then you just see your patient in C2. You have to see your patient every infusion, and sometimes just say, hold them, amivantamab, let's try to make your skin look better, and then we can resume it.
Thank you, Marcelo. It's again a thoughtful explanation of how we can, help our patients with this new toxicity. Now we're at the end of the podcast. So in 1 minute, what do you think will be next for patients with EGFR mutant lung cancer? We know that dapagliflozin has shown some efficacy in the TROPION-Lung05 trial, for example, or in the Athena trial. But tritoxan and ADC against ER3 has also shown efficacy. Ivonescimab in a randomized study conducted in Asia has also shown benefit over chemotherapy, for example. So in your opinion, where we are going and what's the next? 1 minute.
Can I answer the Biagio answer? Clinical trial. We have to put patients in clinical trials. And you said everything. Dato maybe is something interesting for those patients. Patritumab deruxtecan, if you don't have a target. Ivonescimab, I think it's going to be a hit. And sometime we're going to be using this for a lot of patients. But I do think that we should try to pursue biomarker testing. But if it's expensive, I don't have access, the patient doesn't want a biopsy. You have to insist, you have to offer your patient. This week, you just have a patient with a BRAF V600E mutation, and the patient was supposed to get chemo plus amivantamab, and he's now receiving Ozi plus Dara plus trametinib, which is much better for him. So we need to insist in testing, biopsying every time, because we have to remember about histologic transformation. ctDNA, if you have available, I think you can use both things. But I do think that I have more trouble understanding right now how we're going to put our patients in first line, what are we going to choose then second line. Maybe we're going to have time because we have PFS benefit of over 20 months. So we have some time to think about it if we start therapy. And lastly, I think is that we should consider retesting our patients every time, because you can do chemo plus amivantamab to anyone you want to, but you have to test your patients before. And if you have a clinical trial in your country, now I can answer that. The game has changed, Biagio. Now I can use the clinical trial answer. You should put your patient in a clinical trial, of course.
Thank you, Marcelo. It was a great conversation from FLAURA, MARIPOSA, FLAURA2, and all biomarkers. So I'd like to thank you for being with us today. And for everyone else, stay tuned for the next podcast on Here and Now. Goodbye, everyone.